This is part 2 of the last video in this series on interpreting chest x-rays, which is a self-assessment of the knowledge gained from the preceding 9 lessons. Case 9. A 45-year-old man with HIV presents with intermittent fevers and weight loss over 6 weeks. So there's obviously a diffuse bilateral process going on. Is it alveolar or interstitial? There are small, very well-defined, homogeneously spread opacities indicative of an interstitial process. Unlike case 7, in which there were too many lines, in this case there are too many dots. That is, the patient has a predominantly nodular interstitial pattern. What's the differential diagnosis for that? The differential diagnosis is roughly subdivided based on the size of the nodules. In lesson 7, I attempted to place an exact cutoff to the size that differentiates these two categories, but the more I think about it, it's probably too artificial to draw a specific line, and better to leave it more vague as to where the line is drawn between them. In this case, though, these nodules are small enough to be called micronodules, and the combination of their size and significant number would also make this consistent with a so-called miliary pattern. While there is more than one etiology of miliary interstitial opacities, for a patient with HIV presenting with a subacute to chronic febrile illness with cachexia, tuberculosis absolutely must be the primary consideration. Other considerations could include various fungal diseases depending upon the patient's geographic location and environmental exposures. Case 10. A 35-year-old woman with scleroderma presents with subacute progressive dyspnea on exertion. The first thing you noticed is that the lungs look pretty normal. It would be easy for someone in a real clinical setting to quickly say that the lungs are normal and disregard the rest of the film, which of course would be a huge mistake. Now, so far in this self-assessment, I haven't gone through the other chest x-rays systematically using the A through F system. This wasn't because I don't advocate for a systematic method, but was more out of the interest of time and because it would be a pretty darn boring video to hear someone else going through the 15 x-rays systematically, especially when the location of pathology is pretty evident with most. But in this case, the pathology is more subtle, so let's practice the system. First, how is the technical quality? There's no apparent rotation, the entire thorax is in the film, the contrast and exposure look good, and the lung volumes are normal, suggesting the patient's inspiratory effort was good. So then A is for airway. In this case, the trachea is midline and of normal caliber. The carinal angle looks normal. B is for bone. The overall shape of the thorax seems subjectively a little boxy in my opinion. In other words, the lungs are not as tapered at their apices as seems normal, but this doesn't actually mean anything and is probably a normal variant. The clavicles and ribs are unremarkable, but the patient seems to have the tiniest bit of lateral curvature to the spine, known as scoliosis. C is for cardiac and mediastinal silhouette, including the hilum. In this case, while the heart itself looks okay, there's a little fullness to both hyla. What are the etiologies of hilar enlargement? These are the major causes: malignancy, various infections, sarcoidosis, silicosis, pulmonary hypertension, a pulmonary artery aneurysm, and a bronchogenic cyst. Which of these seem particularly likely in this 35-year-old woman with scleroderma? Well, for anyone not familiar with scleroderma, it is a systemic autoimmune disease presenting with some combination of skin changes, esophageal problems, a peripheral vascular problem called Raynaud's phenomenon, interstitial lung disease, and pulmonary hypertension. So in this patient with progressive dyspnea on exertion, pulmonary hypertension is almost certainly the cause of both the hilar fullness and her symptoms. And to appreciate how the central cardiovascular structures line up with the hilar fullness seen here, let me superimpose this image. If we continue with our systematic method, D is for diaphragm, which looks okay. E is for effusions, and more generally the pleura. No pleural disease is evident here. And finally, F is for fields, which as stated in the beginning of this case's analysis, are normal. So in summary, the patient's primary finding is bilaterally enlarged hyla, probably due to pulmonary hypertension. Case 11. A 52-year-old woman presents to her primary care doctor with a 20-pound weight loss over 6 months and intermittent fevers. In the interest of expediency, I'm going to defer the systematic method for this case, though I would still encourage you to examine each film systematically. In this X-ray, there is a large mid-thoracic mass that appears just to the right of midline. Where exactly is that mass? The clue is actually on the lateral film. Look here. What's not present? There should be a retrosternal lucency, which isn't there, suggesting something occupying the anterior mediastinum. So this mass that looks like from the PA film to be to the right of the mediastinum is actually probably arising from within the anterior mediastinum and spreading laterally. Here's a differential diagnosis of masses in either the anterior or superior mediastinum. Of these, given the patient's weight loss and fevers, a lymphoma is most likely. So a large anterior mediastinal mass due to possible lymphoma, which is indeed what she ended up being diagnosed with after biopsy. Case 12. A 58-year-old liver transplant recipient presents with fever, chest pain, hemoptysis, and dyspnea, progressively worsening over the course of a week. At first glance, it may seem like this chest X-ray is showing the patchy, indistinct opacities of alveolar disease. However, if you look more closely, you'll realize that this patient actually has many pulmonary nodules, some of which are quite large. And these nodules are large enough that one would not usually call it a nodular interstitial pattern per se. The differential diagnosis for multiple pulmonary nodules? Cancer, obviously, along with a variety of unusual infectious and inflammatory diseases, and also amyloidosis. There may be some hints as to the diagnosis based on radiographic characteristics of the nodules, but those are really attending radiologist level distinctions. For non-radiologists, such as myself, the better clues are actually in the clinical history. The patient's been sick just for a week, which makes pulmonary mets less likely. But the patient is immunocompromised due to their organ transplantation. This makes all of the infections more likely, and in particular, organ transplantation is a significant risk factor for fungal pneumonia and to lesser extent nocardia, which is an opportunistic bacterial infection rare in patients with an intact immune system. I would summarize the chest X-ray by stating the primary finding is innumerable bilateral pulmonary nodules of varied size, most prevalent in the mid-lung zone, which is consistent with, but not diagnostic, of fungal pneumonia. In this particular case, the patient was diagnosed with pulmonary aspergillosis. Case 13. A 56-year-old man with no prior past medical history presents to urgent care clinic with 2 days of sore throat and fever. The first thing to notice is that the lungs appear to be a little on the small side. If you recall from lesson 3, there should be 9 to 10 posterior ribs visible on a standard inspiratory PA film. If we count the posterior ribs in this case, we see that there are only 8. There are 2 general explanations for this. First, the patient may not have taken a large inspiration, or the radiograph may have been poorly timed, or there is a pathologic process leading to reduced lung volumes. You should never assume the former unless the latter has been ruled out. Aside from the modestly low lung volumes, however, the lungs and heart are otherwise unremarkable. What is interesting, though, is this right here. It kind of looks like the patient may have free air under the diaphragm, that is, pneumoperitoneum, which is often indicative of a surgical emergency. The first clue that this is not pneumoperitoneum has nothing to do with the X-ray, but rather the clinical scenario. The patient is not presenting with any abdominal complaints. So what's going on? Look in the right upper quadrant of the abdomen, where there is obviously a lot of gas. Do you notice these lines here? Those are the natural separations between adjacent haustra in the colon. What's unusual is that there typically is not colon there because the right subdiaphragmatic space is usually occupied by the liver. However, this is an example of an anatomic variant called Chilaiditi sign, in which a loop of colon has become interposed between the liver and the diaphragm. It's usually asymptomatic and just an incidental finding, but a minority of patients with it can develop abdominal pain and colonic obstruction, in which case it is known as Chilaiditi syndrome. So in summary, the primary findings are mildly reduced lung volumes, with otherwise clear lungs and an unremarkable cardiac silhouette, and with the colon interposed between the liver and the diaphragm. The overall impression would be low lung volumes and an incidental finding of Chilaiditi sign. There is no visible pathology associated with the patient's presentation, which is probably due to either a viral URI or possibly strep throat. Case 14. An 80-year-old man with multiple cardiovascular risk factors presents to the ER with progressive, constant chest pain for 2 weeks. First, this is a suboptimal X-ray for the most obvious reason that the bottom of the lungs aren't even included in the film. Aside from that, this is also a great example of a chest X-ray finding that can be easily missed if the radiologist is not provided the clinical history, or if the ordering physician ignores the details of the clinical history when he or she interprets the film themselves. When a patient with risk factors for acute coronary syndrome presents with chest pain, the X-ray is usually ordered to rule out so-called don't miss diagnoses. For example, to make sure the mediastinum isn't wide, suggesting an aortic dissection as the cause of pain, and to make sure there isn't a big pneumothorax or pneumomediastinum. Things like that. My guess is that 9 times out of 10, the ER doc or the internist who orders this chest film, in this context, would conclude that it's normal and then move on to admit the patient for a so-called rule-out MI admission. So what's the problem? It's this. This patient has had constant chest pain for 2 weeks. Assuming that history is accurate, there is no way this patient has acute coronary syndrome. Ischemic pain typically lasts from minutes to hours, and I've never even heard of a case of constant ischemic pain lasting for more than a day. This is relevant because with an acute MI ruled out by history, other less common causes of chest pain all become more likely, which would prompt a much closer inspection of the initial chest X-ray. And if we are being good about going through the film systematically, when we get to the B for the bones, we might notice something abnormal. This rib here, specifically the anterolateral portion of the left fifth rib, appears brighter than the others. It's subtle, but not equivocal. A bone or focal part of a bone that is too bright on X-ray is usually due to bone sclerosis. Here are the etiologies of bone sclerosis from Lesson 4. Of these, osteoblastic metastases are the most common in the elderly population. Most malignancies cause osteolytic mets. The most common tumors to cause an osteoblastic met are prostate, breast, and transitional cell carcinoma. Given this patient's gender and age, an osteoblastic met from prostate cancer is the most likely diagnosis and the one this turned out to be. Though from the film, this could also theoretically be a primary bone tumor or Paget's disease. The last self-assessment case, Case 15. A 63-year-old woman with no significant past history presents to a primary care clinic with hemoptysis for 4 weeks. If we were to go through this film systematically, what do you think about the technical quality? There is one technical problem. What do you notice about the lung apices? On a normal chest X-ray, you can usually see a small portion of the apices peeking up above the medial ends of the clavicles. When you don't see that, it suggests that the film is a lordotic view, meaning the X-ray beam was angled slightly upwards. This is a relatively unusual problem with a PA film unless done intentionally. But nonetheless, this looks like a lordotic film. Aside from that, as with Case 14, this X-ray also has a major pathologic finding, which is easy to miss if you're not thinking about it. Continuing with our systematic method, we move on to A for airway. the trachea looks relatively unremarkable, but what about the right and left mainstem bronchi? Typically, the left mainstem bronchus takes off at a more horizontal angle than the right, but in this case, the left is angled relatively inferiorly, which if you look more closely, is because the entire hilum has been pulled downward. B is for bones, which are normal. But then C for cardiac and mediastinal silhouette leads us to another finding. Although the heart silhouette itself looks okay, the descending aorta is obscured by this unusually shaped triangular shadow. I'll return to that in a second. D is for diaphragm. Now the lordotic view may alter the appearance of the diaphragm a little, but even considering that, the left diaphragm looks a little funny. E is for effusions and pleura. I've certainly seen students and house staff mistake the unusual retrocardiac opacity for a loculated effusion due to its smooth, curving shape, but this is not that. Finally, F is for fields. In this case, at first glance, both fields look normal. But if you figuratively step back and try to look at both lungs at the same time, you can imagine that the left lung is ever so slightly hyperlucent compared to the right. So how can we put this all together? The inferior displacement of the hilum, triangular shaped opacity obscuring the descending aorta, and hyperlucency of the left lung are all due to a collapsed left lower lobe. Lobar collapse is usually due to airway obstruction, and given this patient's presentation with a month of hemoptysis, an endobronchial tumor seems most likely. So that concludes both the lesson and this course on interpreting chest x-rays. I stated at the very beginning my goal was to teach you everything a non-radiologist might need to know about them within the context of the routine care of patients, and I hope you feel I've succeeded. However, as with any skill, watching videos will be insufficient for true mastery, which will also require both deliberate practice and occasional feedback. So I hope you enjoyed this video series. If you did, please remember to like the videos and share them with your friends and colleagues and classmates, and feel free to leave any comments or questions in the space below.